Question 1. A pathologist examines a tissue specimen and performs a qualitative drug screening test to determine if a specific illicit substance is present in the patient's system. The result is either positive or negative. What type of pathology code would be used? A. A presumptive drug class screening code. B. A definitive drug testing code. C. A therapeutic drug assay code. D. A surgical pathology code. Answer: A. A presumptive drug class screening code. This question tests the difference between presumptive, qualitative, and definitive, quantitative, drug testing in pathology. The keywords are qualitative and present, which indicate the test is only looking for the presence or absence of a drug, not the specific amount. Presumptive drug class screening codes are used for these simple positive/negative tests, while definitive tests are quantitative and identify the specific concentration of a drug. A good way to think about it is that presumptive screening asks, is anything there, while definitive testing asks, what exactly is there and how much? Question 2. A patient is diagnosed with cholecystitis. Which organ is affected? A. Liver. B. Gallbladder. C. Kidney. D. Spleen. Answer: B. Gallbladder. This question assesses knowledge of medical terminology, specifically breaking down a term to identify the affected anatomy. The key is to recognize the root word cholecyst-, which refers to the gallbladder, and the suffix itis, meaning inflammation. Therefore, cholecystitis is inflammation of the gallbladder, a small organ that stores bile produced by the liver. Understanding common prefixes and suffixes is crucial for accurately interpreting medical documentation for coding. A simple tip is to remember that chole- relates to bile, and the cyst or sac that holds it is the gallbladder. Question 3. A patient sees their primary care physician for a scheduled E/M visit for hypertension management. During the same visit, the patient complains of a new, painful skin lesion, which the physician decides to remove via shave biopsy. Which modifier should be appended to the E/M service code? A. 24. B. 25. C. 57. D. 59. Answer: B. 25. This scenario tests the use of modifier 25, which indicates a significant, separately identifiable evaluation and management, E/M, service by the same physician on the same day of a procedure. The key is that the E/M service, hypertension management, was distinct from the reason for the procedure, skin lesion removal. Modifier 25 tells the payer that the E/M visit went above and beyond the usual preoperative care included with the minor procedure. For instance, if the patient only came in for the lesion, an E/M would not typically be billed separately. A good way to remember this is, use modifier 25 when the E/M service has a reason of its own, separate from the procedure's reason. Question 4. A patient is seen for a follow-up visit for a healing non-displaced fracture of the right patella. This is the second visit after the initial injury treatment. How should the seventh character be assigned? A. Initial encounter. B. D. Subsequent encounter. C. S. Sequela. D. G. Subsequent encounter with delayed healing. Answer: B. D. Subsequent encounter. This question tests the proper use of the seventh character for injury coding. The keyword is follow-up visit, which indicates this is not the first time the patient is receiving active treatment for the injury. The correct seventh character is D for a subsequent encounter, used for routine care during the healing phase, like a cast change or follow-up evaluation. For example, the first visit in the emergency room would be a initial, but this return visit to the orthopedist is D, subsequent. A good tip to remember is that initial is for the start of active treatment, while subsequent is for all the routine follow-up care afterward. Question 5. A medical report describes a wound as being on the posterior aspect of the trunk, inferior to the scapula. Where is the wound located? A. On the upper chest. B. On the front of the abdomen. C. On the lower back. D. On the side, under the arm. Answer, C. On the lower back. This question tests the understanding of anatomical directional terms. The keywords are posterior, which means toward the back of the body, and inferior, which means below something else. The scapula is the shoulder blade, so a wound posterior to the trunk and inferior to the scapula would be located on the lower back. Accurately interpreting these terms is essential for selecting the correct diagnosis and procedure codes, especially for injuries. A handy tip is to visualize the body in the anatomical position, standing, facing forward, to correctly apply terms like posterior, back, anterior, front, superior, above, and inferior, below. Question 6. A patient is diagnosed with both type 1 diabetes, E10, and type 2 diabetes, E11. According to ICD-10-CM coding guidelines, how should this be coded? A. Code both E10 and E11. B. Code only E10 as it is more severe. C. Code only E11 as it is more common. D. Neither code can be reported together due to an excludes one note. Answer, D. Neither code can be reported together due to an excludes one note. This question tests the understanding of the excludes one note, a critical instruction in the ICD-10-CM codebook. The key concept is that an excludes one note means the two conditions listed cannot be coded together because they are mutually exclusive. Under the code category for E10, type 1 diabetes, there is an excludes one note for E11, type 2 diabetes, and vice versa, meaning a patient cannot have both conditions simultaneously. Therefore, the coder must query the provider for clarification to assign the correct diagnosis code. Think of an excludes one note as a hard stop sign. You cannot report the two codes on the same claim. Question 7. A surgeon performs a novel laparoscopic procedure for which no specific CPT code exists. How should this service be reported? A. Use the CPT code for the most similar open procedure. B. Do not bill for the procedure until a new CPT code is created. C. Use an unlisted procedure code from the appropriate section of the CPT manual. D. Use a miscellaneous HCPCS Level II code. Answer, C. Use an unlisted procedure code from the appropriate section of the CPT manual. This question addresses the correct way to code procedures that are not described by an existing CPT code. The key is the phrase, "No specific CPT code exists," which directs the coder to use an unlisted procedure code. Each section of the CPT manual has unlisted codes, e.g., unlisted procedure, abdomen, that should be used in these situations, accompanied by a special report describing the procedure in detail. Using a code for a similar but different procedure is incorrect and can be considered fraudulent billing. Think of unlisted codes as the proper way to say, "We did something new, and here is the documentation to explain what it was and why it was necessary." Question 8. A patient has a chest X-ray at an outpatient imaging center. The images are then sent to a radiologist at a different location who interprets the results and writes a report. How should the radiologist bill for their service? A. With the CPT code for a chest X-ray and modifier TC. B. With the CPT code for a chest X-ray and modifier 26. C. With the global CPT code for a chest X-ray, no modifier. D. With an E/M code for consultation. Answer, B. With the CPT code for a chest X-ray and modifier 26. This question tests the concept of professional versus technical components in radiology coding. The key clue is that the radiologist only interprets the results, which is the professional component of the service. Modifier 26 is appended to a radiology CPT code to indicate that only the physician's interpretation and report, the professional part, are being billed, while the imaging center would bill the same code with modifier TC for the technical component. Think of it this way: modifier 26 is for the brain work of reading the scan, while TC is for the machine work of creating the image. Question 9. An established patient presents for an E/M visit. The provider documents one stable chronic illness, orders one unique test, and notes a low risk of morbidity from patient management. According to the 2021 E/M guidelines, what is the level of medical decision-making, MDM? A. Straightforward. B. Low. C. Moderate. D. High. Answer: B. Low. This question tests how to determine the overall medical decision-making, MDM, level for an E/M service. The key is that to qualify for a certain MDM level, at least two of the three elements, problems, data, risk, must meet or exceed the requirements for that level. Here, the stable chronic illness and low risk both fall under low MDM, and ordering a single unique test falls under limited data, which also aligns with low MDM. Since all three elements meet the criteria for low MDM, the overall level is low. A helpful way to think about it is that you need to find the second best element to determine the final score. Question 10. A Medicare patient receives a standard wheelchair, K0001, for home use from a durable medical equipment, DME, supplier. Which code set is used to report the wheelchair? A. CPT. B. ICD-10-PCS. C. HCPCS Level II. D. ICD-10-CM. Answer: C. HCPCS Level II. This question is about identifying the correct code set for supplies, equipment, and specific drugs. The key phrase standard wheelchair points to durable medical equipment, DME, which is reported using HCPCS Level II codes, not CPT codes. HCPCS Level II codes are used for products, supplies, and services not included in CPT, such as ambulance services, DME, and injectable drugs. For example, while a doctor's service is a CPT code, the crutches or wheelchair they prescribe is a HCPCS Level II code. Remember this tip: if it's a thing, supply, drug, equipment, rather than a service, procedure, visit, it's likely a HCPCS Level II code. Question 11. A medical coder is working from home and discussing a patient's protected health information, PHI, over the phone with a colleague in a public place where others can overhear. Which core principle is being violated? A. Medical necessity. B. The Stark Law. C. The HIPAA Privacy Rule. D. The False Claims Act. Answer: C. The HIPAA Privacy Rule. This question assesses knowledge of federal regulations, specifically HIPAA. The key concept is the protection of patient information, and the phrase protected health information, PHI, is a direct link to HIPAA regulations. The HIPAA Privacy Rule establishes national standards to protect individuals' medical records and other identifiable health information by requiring appropriate safeguards. Discussing PHI in a public place where it can be overheard is a failure to implement reasonable safeguards and a clear violation of this rule. A simple tip is to remember that HIPAA is all about keeping patient information private and secure, no matter where you are working. Question 12. A patient with end-stage renal disease, ESRD, on dialysis presents with symptomatic anemia. The provider documents anemia in CKD. How should this be coded? A. N18.6, D63.1. B. D63.1, N18.6. C. D64.9, N18.6. D. N18.9, D63.1? Answer: A. N18.6, D63.1. This scenario tests correct diagnosis sequencing based on ICD-10-CM instructional notes. The key phrase anemia in CKD directs the coder to follow the guidance found under code D63.1, anemia in chronic kidney disease. The codebook states to first code the underlying chronic kidney disease, CKD, which is N18.6 for end-stage renal disease, followed by the code for the anemia, D63.1. This code first note is a mandatory sequencing rule that shows the causal relationship between the two conditions. An easy tip is to always check for code first or use additional code notes when dealing with manifestation codes like anemia due to an underlying disease. Question 13. A patient is diagnosed with acute cystitis due to an E. coli infection. How should this be coded according to ICD-10-CM guidelines? A. N30.00 for acute cystitis and B. 96.20 for E. coli. B. N39.0 for UTI, site not specified. C. B. 96.20 for E. coli and N30.00 for acute cystitis. D. N30.01 for acute cystitis with hematuria. Answer: A. N30.00 for acute cystitis and B. 96.20 for E. coli. This question tests the use of combination codes and use additional code notes in ICD-10-CM. The key is to find the code for acute cystitis, N30.00, and check for instructional notes. Under category N30, there is a use additional code note that instructs the coder to also identify the infectious agent, such as E. coli, B. 96.20. The sequencing rule requires the primary diagnosis, the condition, to be listed first, followed by the code for the causal organism. For example, you first report the disease, cystitis, and then the germ that caused it, E. coli. Always look for these instructional notes, as they ensure you are capturing the full clinical picture. Question 14. A patient undergoes a colonoscopy where a polyp is removed from the transverse colon. During the same operative session, the physician also performs a biopsy of a separate, distinct lesion in the sigmoid colon. Which modifier would be appended to the biopsy code? A. 51. B. 59. C. 76. D. 25. Answer: B. 59. This question tests the appropriate use of modifier 59, which identifies a procedure or service as distinct from other services performed on the same day. The keywords are separate, distinct lesion, indicating that the biopsy was not part of the polyp removal but was performed on a different anatomical site during the same session. Modifier 59 tells the payer that the two procedures are not bundled and should be paid separately because they were performed on different locations. For example, removing a mole from the arm and another from the leg in the same visit would require a modifier 59 on the second procedure code. Remember, modifier 59 is used for a different session, different procedure, different site, or different organ system. Question 15. A patient had a major surgery on March 1st with a 90-day global period. On April 10th, the patient returns to the same surgeon for a new, unrelated problem, a sinus infection. The surgeon performs an E/M service for the sinus infection. Which modifier should be appended to the E/M code? A. 24. B. 25. C. 57. D. No modifier is needed. Answer: A. 24. This scenario tests the use of modifier 24, which is for an unrelated E/M service by the same physician during a postoperative period. The keywords are unrelated problem and postoperative period. Since the E/M service for the sinus infection is completely separate from the reason for the original surgery, modifier 24 is used to indicate this to the payer so the E/M service can be paid. For example, if a patient is recovering from knee surgery and sees the surgeon for a new case of the flu, that flu visit is billable with modifier 24. A simple way to remember is, modifier 24 is for an unrelated E/M during the global time frame. Question 16. A physician spends 45 minutes with an established patient, with more than half of that time spent on counseling and coordinating care regarding treatment options. The documentation fully supports the time spent. According to CPT guidelines for office visits, how should this E/M service be leveled? A. Based on the three key components of history, exam, and MDM. B. Based on the total time spent on the date of the encounter. C. It cannot be leveled based on time since it was an established patient. D. Based only on the complexity of medical decision-making. Answer: B. Based on the total time spent on the date of the encounter. This question tests the rules for time-based E/M coding. The critical information is that more than half of the 45-minute visit was spent on counseling and coordination of care, allowing time to be the controlling factor for code selection. For outpatient E/M codes, like 99,202 to 99,215, the final code level can be selected based on either the total time spent on the day of the encounter or the level of medical decision-making, MDM. Since the time is documented appropriately, the coder would select the E/M code that corresponds to 45 minutes for an established patient. The key takeaway is that when counseling dominates a visit, time, not MDM, can be used to justify the E/M level. Question 17. A patient with a family history of colon cancer, but no personal history or symptoms, presents for a screening colonoscopy. Which type of code should be reported as the primary reason for the encounter? A. A code for abdominal pain. B. A code for a malignant neoplasm of the colon. C. A Z code for screening for malignant neoplasm. D. A code for personal history of malignant neoplasm. Answer: C. A Z code for screening for malignant neoplasm. This scenario tests the correct use of Z codes, which are used for encounters for reasons other than a current illness or injury. The keywords screening and family history indicate the patient is not being treated for a current problem, but is undergoing a preventive service. In this case, the appropriate Z code for a screening colonoscopy, Z12.11, would be the primary diagnosis, followed by a secondary Z code for the family history of colon cancer, Z80.0, to establish medical necessity. Remember, Z codes answer the why for the visit when the patient isn't sick, such as for a screening, a follow-up, or to show a history of a condition. Question 18. Before providing a service to a Medicare patient that is unlikely to be covered, what form should the provider have the patient sign to ensure they can bill the patient if Medicare denies the claim? A. HIPAA Notice of Privacy Practices. B. Assignment of Benefits, AOB. C. Advance Beneficiary Notice of Non-Coverage, ABN. D. Patient Consent for Treatment. Answer: C. Advance Beneficiary Notice of Non-Coverage, ABN. This question focuses on a key concept in Medicare billing and compliance. The crucial phrase is unlikely to be covered, which triggers the need for an Advance Beneficiary Notice of Non-Coverage, ABN. An ABN is a written notice given to a Medicare beneficiary before providing services that the provider believes may not be paid for by Medicare, transferring financial responsibility to the patient if they agree to receive the service. For example, if a patient wants a screening test more frequently than Medicare allows, an ABN must be signed beforehand to bill the patient. Remember, no ABN means no ability to bill the patient if Medicare denies the claim for not being medically necessary. Question 19. A surgeon performs a major surgery with a 90-day global period on May 1st. The patient returns to the same surgeon on June 15th for a follow-up visit related to the surgery. How is this follow-up visit coded? A. Bill an appropriate E/M code with modifier 24. B. Bill an appropriate E/M code with no modifier. C. The visit is not reported separately as it is included in the global package. D. Bill a postoperative CPT code. Answer: C. The visit is not reported separately as it is included in the global package. This question assesses understanding of the surgical global package concept. The key information is 90-day global period and follow-up visit related to the surgery. All typical preoperative and postoperative care provided by the surgeon related to the original procedure is included in the payment for that surgery and should not be billed separately. Since the June 15th visit is for routine follow-up within that 90-day window, it is considered part of the global package. A simple rule to remember is, if the visit is for normal recovery care from the surgery, by the surgeon, within the global period, it's already paid for. Question 20. A patient is diagnosed with bilateral carotid artery stenosis. The ICD-10-CM code for this condition is I65.23. What does the sixth character 3 signify? A. Unspecified side. B. Right side. C. Left side. D. Bilateral. Answer: D. Bilateral. This question tests the concept of laterality in ICD-10-CM coding, which specifies the side of the body affected. For many diagnosis codes, the final characters indicate whether the condition is on the right side, left side, or both. In this case, the keyword is bilateral, which means affecting both sides. The code I65.23, occlusion and stenosis of bilateral carotid arteries, uses the character 3 to represent bilateral, providing the highest level of specificity. A good habit is to always code to the highest specificity available, using bilateral codes when documented instead of separate codes for the right and left sides. Question 21. A physician performs a debridement of a 15 SQCM wound, subcutaneous tissue, and also applies a skin substitute graft measuring 15 SQCM to the same wound. How should this be coded? A. Code only for the skin substitute graft application. B. Code for the debridement and the skin substitute graft application separately. C. Code only for the debridement service. D. Use an unlisted procedure code for the combined service. Answer: A. Code only for the skin substitute graft application. This question tests the concept of code bundling, where one procedure is considered an integral part of another. The key is understanding that surgical preparation, such as debridement of the wound bed, is included in the CPT codes for skin substitute graft application when performed at the same site. The CPT guidelines state that you should not separately report debridement when it is performed immediately prior to and at the same anatomical site as a skin graft. Therefore, only the code for the application of the skin substitute graft should be reported. Always check the CPT code descriptions and parenthetical notes to see what services are already included to avoid unbundling. Question 22. A patient sustains a poisoning by accidental overdose of a prescribed anti-allergic drug. The correct ICD-10-CM code is T45.0X1A. What is the purpose of the X in this code? A. To indicate the encounter is for a sequela. B. To signify the code is for an external cause. C. To act as a placeholder so the seventh character is in the correct position. D. To mark the code as unspecified. Answer: C. To act as a placeholder so the seventh character is in the correct position. This question is about the function of the placeholder X in ICD-10-CM coding. The key concept is that some codes require a seventh character to provide more detail, like initial or subsequent encounter, but the base code is not 6 characters long. The X is used to fill the empty character spaces so that the 7th character always lands in the 7th position. In the code T45.0x1a, the X is a placeholder filling the 6th position so the 7th character is correctly placed. A great way to remember it is, X marks the spot to ensure the 7th character is in the right place. Question 23. A patient with established hypertension sees a nurse practitioner, NP, in a cardiologist's office for a follow-up visit. The cardiologist is in the office suite but does not see the patient. The NP performs an E/M service that meets all incident-to requirements. How should this service be billed? A. Under the NP's National Provider Identifier, NPI. B. Under the cardiologist's NPI. C. It cannot be billed as it was not performed by the physician. D. With a special CPT code for a nurse visit. Answer, B. Under the cardiologist's NPI. This question tests the incident-to-billing guidelines, which are a key concept for non-physician practitioner, NPP, services. The crucial information is that the service meets all incident-to requirements, including the physician's direct supervision by being in the office suite. Incident-to rules allow services provided by an NPP to be billed under the supervising physician's NPI, typically resulting in a higher reimbursement rate. For this to be allowed, the patient must be established, the physician must have initiated the plan of care, and the physician must be immediately available. Think of incident-to as the NPP service being incidental to the physician's overall plan of care. Question 24. A patient is diagnosed with Crohn's disease. This condition primarily affects which body system? A. The respiratory system. B. The integumentary system. C. The digestive system. D. The endocrine system. Answer, C. The digestive system. This question tests basic anatomical and physiological knowledge by linking a specific disease to its corresponding body system. The key is to know that Crohn's disease is a type of inflammatory bowel disease that causes chronic inflammation of the gastrointestinal, GI, tract. The GI tract, which includes the intestines, is the main component of the digestive system. Knowing which body system a condition affects is fundamental for navigating the ICD-10-CM codebook, as it is organized by these systems. Think of this as the first step in finding the right chapter in the codebook to begin your search. Question 25. A patient is admitted with pneumonia and the provider documents that the patient also has sepsis due to the pneumonia, but the sepsis was not present on admission. According to official coding guidelines, what should be the principal diagnosis? A. The code for pneumonia. B. The code for sepsis. C. The code for the infectious organism. D. Both sepsis and pneumonia can be principal. Answer, A. The code for pneumonia. This question tests a complex sequencing guideline for sepsis that often confuses new coders. The key information is that the sepsis was not present on admission, POA, and developed after the patient was admitted for pneumonia. In this specific inpatient scenario, if the sepsis develops during the encounter and was not the reason for admission, the underlying systemic infection, pneumonia, should be assigned as the principal diagnosis. The code for sepsis would then be assigned as a secondary diagnosis. A helpful tip is to always ask, what was the primary reason the patient was admitted to the hospital? That will usually be your principal diagnosis.